Okay, I'm going to turn it over to Kimberly Fowler of the National Council of Urban Indian Health, and she's going to tell us a little bit about another community level program for support. Kimberly?
Excuse me, thank you. I really appreciate following Dave. I think we have a lot of work that's intersected very well around the community health workforce. And I am definitely very honored to be a part of this panel and thank the organizers for their acceptance of the National Council of Urban Indian Health on this panel. Again, my name is Kimberly Fowler. I am the Vice President of the Technical Assistance and Research Center here at NCUI, as we refer to it. The NCUI, I did want to provide a brief background on our organization, the actual healthcare centers that we provide representation to, and a little bit about the Community Health Representative Program that's coming out of the Indian Health Service as a way to talk through solutions, challenges, and strategies that have been used. So for the National Council of Urban Indian Health is a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas, which actually makes up over 70% of the American Indian Alaska Native population. This is accomplished through 41 Title V urban Indian organizations under the Indian Health Service. And actually these UIOs are healthcare centers, federally qualified health centers, in which we as an organization strive to improve the health and the lives of American Indians and Alaska Natives. So I did want to share a little bit about the Indian Health system in case that was unbeknownst to some of you that are watching today. NCUI provides critically needed technical assistance, training, policy support, and other areas of services to UIOs that are located throughout the United States as part of this Indian Health system, which actually is made up of a federally run facilities, which is IHS, tribally run facilities that have compacts and contracts to provide healthcare to their communities on tribal lands, and by urban Indian organizations, which are funded nonprofits that receive contracts through IHS to provide that health care as well. We know that healthcare follows the patient no matter where they live, by the work that we do. And I wanted to share with you that there are 41 urban Indian organizations located within 22 states and in 38 cities across the nation, as relevant to the 12 IHS regions that are showed here. So you can see that there are a vast amount on the Midwest, West Coast of the United States, with a few that are on the East Coast as well. As I mentioned, these 41 UIOs are across the nation, and they do or can be near tribal lands. However, they are specifically in urban areas, urban cities, or suburban areas within the larger state. Services provided at these UIOs come in a variety of ways, depending on the funding structure of the site or the facility. This can include primary health care, such as diabetes care and prevention, outpatient and patient mental health treatment. Social and community services are a high area of use in which we do strive to provide and support the social determinants of health that can contribute to negative outcomes within the Native population. So education and housing are some of those in which there are services that are able to provide vouchers or ways in which they can expand upon the resources within families. There is a high need and ability to provide traditional medicine practices, which supports cultural activities and ceremonies for a holistic approach to health, which is mind, body, and spirit. And we just know that these service types span across a variety of UIOs, whether they're outreach and referral facilities to full ambulatory facilities that have such specialty care, as well as residential treatment centers. So this requires an expansive coordination of care that is primarily supported by a non-clinical public health workforce. And we know that the public health workforce across Indian country is in essence a way to complete the continuum of care for primary care patients in Indigenous communities through sources such as community health representatives. So I definitely concur with Dave's presentation around the health core, and also understanding how community health representatives within Indigenous communities are providing services to support communities. So there are definitely several supports that we've seen CHRs can provide through. Most specifically our community health educators or public health educators, typically providing fail prevention in this time of COVID, hand washing, education, nutrition, even breastfeeding and maternal health and childcare services, I should say, to promote immunizations. Around HIV, AIDS, and STDs, there are definitely an important staff to help coordinate care and services to community members, as well as provide prevention and education around PrEP and PEP. And actually, one of the most impactful national public health programs comes out of Indian country. It's called the Special Diabetes Program for Indians, or also known as SDPI. It is a diabetes prevention program or lifestyle intervention program that has seen a 54% reduction in adult kidney failure from its launch back in 1988 to this time of present. So we know that it is important to be able to provide education in the home through home visitors. Also, another reference point or name for the CHRs in these communities are home visiting programs. They're also able to provide those social supports around WIC, maternal, infant, and child development programs, really offering support for infant and child developmental prevention and education, providing those programs in the home so that mothers or even infants and young children may or may not have to go directly to the clinic. We know that transportation is sometimes a barrier to access to care. And so this really helps in connecting the dots and providing linkage in the home in that way that an individual doesn't necessarily have to leave. There's also early childhood education programs in which CHRs work through, really helping to provide in the home setting, pre-Head Start and preschool programming. General wellness programs such as fitness, nutrition, education can happen in the home, but also happen at the UIO facility itself, where there's actually gyms and availability for nutrition and cooking classes, for traditional foods preparations, for education on that, and just providing a wellness center and that offers these types of trainings and activities really helps promote health and healthcare in the community. I also lastly would point out on this slide, there's coordinated school health programs where our UIOs and even CHRs are able to go into local schools and deliver some of the health services and prevention and education practices that could be shared with youth, as well as in-home healthcare programs for elders and disabled populations, which is really important. So all of these community-oriented supports do have CHR health workers in common. They help to facilitate access to quality and culturally competent services and really provide that linkage between health and social services through this programming. I wanted to highlight on the Indian Health Service CHR program itself, which is a national program that was established in 1968. That provides training and management of over 1,600 frontline public health workers across Indian country, across 250 tribes. And we know that there's an estimated 150 CHRs specifically in urban areas providing these services. They are trusted members of the community. They provide that close understanding of the community language and its traditions, and really just provides an opportunity to continue health promotion in a way that is culturally sound and from a trusted individual that may even be neighbors within the community itself. As I mentioned, the CHRs serve as a linkage between clinical settings, but we also know that this is assisted through providing transportation to health visits, outreach is provided, community education, informal counseling, social support, and advocacy. We know that there is there is a need for patients to be able to advocate for their own healthcare. And through the work of a CHR, they're able to actually work with hospital providers, practitioners, in ensuring that an individual can receive the most accurate care, as well as culturally competent care for community-oriented health services. So today, the CHR program is actually the largest tribally contracted and compacted program, with more than 95% of CHR programs being directly operated by tribes. And this does come through a federal authority, the Indian Healthcare Improvement Act. We also know that there are funding mechanisms other than IHS that provide for CHRs, which really benefits UIOs, which don't always have the benefit of receiving the CHR program funding. And so home visiting programs through local and state health departments can be provided, as well as private funding can also be provided in order to ensure that CHRs have the support and the resources to continue their work. As I mentioned, in the Indian Healthcare Improvement Act, it does provide this programming for tribes, but not necessarily for urban Indian organizations with funding. I lastly wanted to share about the training opportunities for CHRs. And so IHS itself provides skills management training, whether it's from basic skills to maintenance and certification skills. But there's also ECHO programs that have come about through the pandemic, in which there are community level response trainings that are provided through the University of New Mexico, as well as the Indian Country ECHO CHR program series, which is really helpful in providing and emphasizing on the social determinants of health and the public health scope of practices a CHR can provide by providing that training. So for CHR outcomes, we know that the CHR programs has been successful in spite of limited or no funding to UIOs. It is definitely a way to provide tribally cultural competence, which can increase health access, can also increase health coverage, as they are also sometimes trained in providing health insurance registration and coverage for access to care. Through CHRs, we see a reduction in hospital readmissions. That means that there are less emergency room visits due to the maintained and sustained practices that happen during those visits. The CHRs have also contributed to lowering mortality rates through sustained monitoring of health for clients. We've seen improved maternal and child health outcomes through those immunizations and well-timed visits that can happen. And through COVID-19, we've seen the prevention efforts and vaccination registrations also occur through CHRs, as well as contact tracing can happen and be supported through a CHR. So as far as challenges, solutions, and opportunities, the American Indian Alaska Native community has endured many operational and financial barriers before COVID-19, and we only saw these really be exacerbated through COVID-19 itself. And so advocating for funding increases or inclusions is a continuous area of need, one that NCUE really takes to heart and really tries to provide a catalyst for UIOs to fight for dollars that they are so greatly needed to provide quality, culturally competent, and excellent services. Throughout the pandemic, we've seen huge wins around gaining enacted COVID-19 and omnibus bills, in which we saw $62.7 million for urban Indian health in fiscal year 21, some of which was part of the CHR program itself. And so we're happy about those funding advances. We know that as the COVID-19 pandemic continues, patients are still adjusting to returning for preventative or chronic care. And so local IHS hospitals have attempted to deter patients from heading to emergency rooms. And through CHRs, they're able to do so with providing that in-home care, or at least having teleconferences that can occur to keep track of patients' maintenance of chronic disease needs. Currently, we know that patients are slowly returning to the clinics, but the workforce shortages have proven to be another hurdle for the Indian health system. So staff recruitment and retention is always a sometimes a barrier that we see within all systems of care. We know that the Great Resignation is occurring, and it's left crucial positions vacant. So urban Indian organizations have had to compete with for-profit health agencies that offer higher salaries, remote opportunities, and sign-on bonuses. And so as a response to this, many urban Indian organizations have moved to create flexible hours, including continuing education benefits or even negotiating salaries in order to sustain their staff. We know that this workforce shortage is ongoing, it may continue, and so even thinking about opportunities to provide hazard pay is something that has been utilized across UIOs themselves. We know that UIO staff have experienced a plethora of workforce challenges, which include compassion fatigue, burnout, and mental health obstacles. And so NACUI has actually aided in this process by providing mental health workshops that allow UIO staff and community members to acknowledge their grief and loss, create healthy boundaries and relationships, and use cultural traditions to build safe spaces. These attendees evaluations have shown that it's been a supportive way of providing a welcome and needed mental health addition to their day-to-day activities as well. IHS actually recently launched the National Health Coach Pilot Project, kind of similar to the Health Pro project that we heard about, but it is a much anticipated effort to deliver health coach training to community and health professionals in Indian country. This pilot project includes 2 cohorts of 50 participants, which will start a 6-month training from April to October 2022. And it does provide an opportunity for community and healthcare professionals working across tribal communities and clinical settings to provide education to Native patients and communities with the hope of understanding the feasibility of establishing a health and wellness coach and behavior change approach at the clinical and community levels at the end of this pilot that is going on or about to start. Within the NACUI itself, I also wanted to share about our CDC Project First Line project, in which the NACUI's infection prevention and control is providing training on infection prevention and control to support standardization of all policies, procedures, and protocols across the healthcare system. We know it's important that we view and develop a system in which the healthcare system itself incorporates primary and secondary public health interventions as key parts of tertiary care services, in which we include CHRs as, by standardizing policies, procedures, and protocols across the healthcare system. This will really be helpful in ensuring that CHRs are able to coordinate, are present, and are part of the record, the electronic health record, in which they are providing that support to a patient so that providers can utilize that information in informing their diagnoses and treatments. And then lastly, I wanted to share that we also know that there needs to be more funding to support the National CHR program for UIOs themselves in order to expand the work in urban areas. And then lastly, from this slide, I want to share that we also need to offer support defined by the public health workforce itself. So each type has a different need. For example, for public health workers that see trauma consistently, offering support to ensure public health employees are centered, healthy, and well to continue their work. So really looking at ways in which we can meet the public health workers itself and their needs around trauma and trauma-informed care. So with that, I'd like to just share a special thank you for being a part of this panel. And also just wanted to add that our community health representatives across Indian country are not only just going into homes, but also providing that community support when we think about the fact that many urban American and Alaska Natives have left their tribal homes and their tribal lands and even some of their traditional practices. And so providing that opportunity to have that culturally competent care, to know someone that understands and will be able to factor in making best practices for their healthcare as well. Thank you.
Thank you so much, Kimberly.